So I work on the topic of chronic pain, as we've just discussed, which I would call, call it a cause as well as a symptom of crisis. And it's a topic which is exactly what we heard earlier. It's an anti-hope topic, but I hope that we can also generate hope through research for basically dealing with chronic pain. So chronic pain is something that either rises on its own, and we'll see examples of that. For example, when we have injury of some kind, or it can also be a symptom of disorders such as metabolic disorders, diabetic neuropathy, for example, or if you have cancer and the cancer spreads to your spine and big bones and so on, and particularly, of course, inflammatory disorders. I think most of us very aware of arthritis and other such. So the statistics for chronic pain are absolutely staggering. And this is one of the reasons why I've never been able to leave this topic once I started, because the more we worked on it, the more we realized in our years how prevalent it is, and how basically how difficult to target it still remains. So even now, every fifth European suffers from chronic pain. Every 10th person in the world will suffer from chronic pain lasting at least 7 years. And whenever you've been in pain for a short time, or maybe a day or two, you remember how it felt and imagine how it feels. And that's why it's anti-hope. And what is also very staggering as a pharmacologist for me to see is that every day, about 15 billion analgesic medications are taken worldwide. So it seems huge demand. What fascinates me about chronic pain is not that it's something just somatic, where I could talk about body parts and neuronal mechanisms and so on, but it's very deeply emotional. And we think that chronic pain is highly related to mental defeat. It actually leads to mental defeat, or mental defeat can lead to chronic pain. As you see here, it's just one example. This is a study I purposely took a study from South Korea, because it's also very important to look at different cultural angles to chronic pain. But here you see that with the increasing number of somatic pains, you have this phenomenal rise in the number of suicide attempts and comorbidities with depression and anxiety. So the absolutely staggering statistics. And in the end, of course, for a person, the sufferer, chronic pain is a very deeply personal insult to themselves, right? It's like an attack on your own psyche. But it also, if you look at society in large, then it is something very prevalent, because you see here chronic pain in the US currently is more prevalent than depression, diabetes, or even heart disease. And we have an enormous, staggering socioeconomic cost also of chronic pain, because chronic pain leads to work absenteeism like nothing else does. So the question then comes about is, why would evolution fit us with a system that's just going to, basically more or less ruin our lives, right? But exactly that was not the point. So chronic pain was designed, or pain was not designed to be a crisis, but it's actually meant to prevent a crisis. It's meant to prevent us from making mistakes that would lead us to have very severe body harm. And pain is something that a child learns very early. I would even argue that, the very moment a child is born and afterwards starts to crawl around and even learns to sit or learns to stand, this comes because they learn it's very painful. It's very painful to walk on your arm. It's very painful to walk on a foot which is turned the other way around. So then they learn, oh, I have to put my foot flat, because every other way is highly painful. And in fact, this has, of course, kept also scientists busy throughout our history. So Charles Darwin, in his essay, The Expression of Emotions, in Man and Animals, described pain as something which is essential for the survival of species. And he called it a homeostatic emotion, just like thirst or hunger. We know that pain is associated, even if it might be acute, it is associated with this major hurt component, which is an attack on ourselves. And then you can ask, why does pain have to be so painful? If it's meant to be a didactic signal, couldn't it have just been a little bit less hurtful? Well, the problem is that the negative emotion is what is leading to pain being such a such an excellent teacher. It teaches us. Why? Because it hurts, and it is very negative, and only because it's very negative we learn to avoid it again, right, throughout our lives. Unfortunately, this aspect of negative emotions, which is important as an instructive signal, is exactly what becomes highly debilitating when pain becomes chronic and when it loses its protective function. Because a pain, I won't call it a patient, and let's just say an individual with experience of pain, will say pain, chronic pain changes everything about themselves. It fragments their personalities. And if you look at this quote from one of the chronic pain survivors, they say, I wish people could distinguish the moments when it's really me talking, myself, my character, my individuality here, talking and acting, from those when my pain is overwhelming and just overtakes every decision. Of course, pain has therefore also found expression throughout history in literature and art. Virginia Woolf, for example, said, let a sufferer try to describe the pain in his head to a doctor, and language at once runs dry. Somewhat paradoxically, we have 200 different words to describe a headache, because there are more than 50 types of headaches. So pain, also basically influences language, and it also has influenced art throughout. Frida Kahlo is one of the most celebrated survivors of chronic pain. She had an accident early on in life, and suffered from chronic pain throughout her life and expressed it in her art. So, of course, then one could ask, is chronic pain a cause or a symptom of a crisis? And this brings me also then to the main part of my talk. Uh, we would correlate that in our field with a question as to whether chronic pain is a disorder by itself. Or is it a symptom of something else, right? And I'm just bringing you a simple example now with headache. And the way we try to distinguish this aspect is by calling it primary versus secondary headache. So, for example, in terms of headache, where you have the headache that cannot be attributed to another medical conditions, such as migraine is one such example, you'd say it's a primary headache because that is the problem by itself. But sometimes headache can actually be indicative, and then again, it makes sense. It might be indicating a brain tumor, it might be indicating you have had stroke or some meningitis, and there this kind of secondary headache, although it is very painful, of course serves a purpose. And so in our field we now distinguish, and it's also something fascinating for me because I've been working on pain since I'm a graduate student, and the definition of pain keeps changing, which you wouldn't think, and the types of pain, how we call them, also keeps changing. But this is exactly what I'd like to also reflect on, the past, present, and future. So we now recognize pain, at least we classify them as something which is nociceptive pain, which is what it was meant to be, right? It was meant to be the body's alarm system. It can be activated by a harmful trigger. It sends signals to the brain and says, take care. And this is the kind of pain that saves lives, right? Because imagine now a heart patient who's just had a chest pain and arm pain, and they immediately know they might be having a heart attack, and they can immediately take their medicines. Then we have, and so I'd say this is legitimate and helpful, but then we have neuropathic pain, and this is a byproduct. So it is something that is legitimate and serves a purpose initially because maybe you've had some sort of trauma, maybe you've had, some sort of chemical reaction. Maybe there's a tumor that's invading your nervous system, and then your nervous system reacts to it and says, oh, I'm feeling something, so it makes sense. Unfortunately, however, the nervous system then also gets damaged in this process, and this damaged nervous system cannot regenerate again. And so this sort of change in the nervous system, which is really a degenerative change, then serves no purpose, and it becomes a disease by itself. It is the most intractable type of pain. This is pain that we cannot treat at this time. And then there's a whole series of disorders or conditions, if you want to call them, such as IBS, so inflammatory bowel syndrome, where the individuals who suffer from that will say they feel pain, they feel enormous pain in their bellies. But if you go and look with a gastroenterologist, or if you do any types of scans or biopsies or so, there's absolutely no problem with the gastrointestinal system. And in the past, people like that, it was called oh, it's something psychological, right? And they were sort of written off, and then they were told to take long walks and do breathing exercises and so on. But this is actually also very real, where we can now, with the help of modern technologies, see that there are changes in the way the nervous system reacts, even though there's no trigger of any kind. And this type of pain, unfortunately, serves no purpose at all. It is the disease by itself. So you might ask then, how can this come about, right? So if with a very quick now look at the neural pathways of pain that lead to this sort of crisis, it was this whole system was designed such that nerves in different parts of our body, in the skin, if you will, if you want to now talk about inputs coming from outside, can sense a stimulus and then pass it on basically to the spinal cord. This is the area you have in our spines, right, in the back, and this is where pain is processed and relayed to the brain, where a very large number of areas are activated in the brain, and that finally lead to the percept of pain. So one major understanding that we have reached in the field is that pain is only pain when the brain says so. And this will become important later when I talk about the political exploitation of pain. Yeah, so pain perception necessarily involves sort of a sensory pathway leading to sensation, but it is not pain if there is no emotion. And that distinguishes pain then from other senses. So if that is true, then you might ask, okay, so if there is more sensory input, whether be it within your body, right, from the gut, for example, or from outside, does that equate to more pain? If you just look at this as a linear pathway, yes, we might say more sensory input leads to more pain. But unfortunately, that is not, I mean, not unfortunately, this is what we have learned over time, that it is not true. And knowing that I'm giving a talk after Jonas, I, of course, could not pass up the, the chance to talk about a little bit about history. So here we have René Descartes in his essay in 1664, Treatise of Man. He was the first to describe how pain comes about. And the beauty is, I mean, he got lots of things right? I mean, imagine all those hundreds of years ago without having an MRI or a CT scan or what have you. So he imagined pain to be a product. He called it's a thread and a bell system. So there's a thread, and he realized it's a spinal cord and so on. He thought it was some sort of a fluid that travels. That he got wrong, right? Nevertheless, he was very right, that it goes to the brain, because at that time people thought the whole, your feelings, everything are in your heart, right? Your soul is anatomically in your heart, and every emotion is in your heart, which we know is not true. So he got the brain right, and then he said, when you pull the thread, the bell rings at the end of the thread, and that's how you feel pain. So that would, of course, also indicate a linearity. And I have to tell you, this is something that I also realized. I mean, I'm ashamed to say this, but only more recently, I mean, about 10, 15 years ago, I finally also, although I've been studying this system, realized, you know what? It is not really linear, because strong pain does not necessarily signal strong input. So it's because pain perception is really context dependent, right? So it does not scale linearly. And so our modern view, going from Descartes here to now the 21st century, is that yes, we have this system which basically goes from the periphery to the brain. We have the pain experience, but it's not linear, because either it can change via prior experience. It can change based upon your expectation or attention, how much attention you give it to it. Of course, it can change based upon your mood, how anxious are you, how depressed are you, and so on. And as neurobiological correlates or mechanisms of that, we find lots of neurochemical changes. We find changes in function. We find changes in structure. There are changes, of course, in the genetic makeup and epigenetics that lead to this aspect. And the second thing we realized is that it's not just a one-way street. So our brain actually has a lot of control over other aspects of the nervous system that regulate pain. This we call as descending or top-down modulation. And this is how you can suppress or also amplify pain upon will. And this is important because I mean, if you talk about hope, you can also talk about hope, and you can actually recruit hope is as a way of getting over pain. And what it would do, I would bet, is that it would actually recruit these top down modulatory systems to suppress pain even at the very point of inception. So this is what we're finding more and more, that the brain can actually talk to every single nociceptor that we have in our skin. Now, this is something that sounds a little bit abstract, and I also want to tell you why I came rather late also to this sort of realization. One part of it was because we have this collaborative research center on pain here. I'm very lucky that I have a huge number of colleagues and they bring with them all these experiences of patients. So listening to the experiences of patients really changed my view. But also instrumental there was a story of two nails. So we haven't had lunch yet. I know you had something to eat. I hope you're not going to feel terrible looking at this. This is one of the only two gruesome images, I promise, I'm going to show. But imagine this poor person, right? This was a construction worker, and he was in England. He was jumping from one plank to another, and that's when it happened, right? I mean, can you imagine the pain this poor guy was in? This was awful. All of his colleagues, they dropped their tools, they rushed to him, they carried him. They were so upset. Everybody was very upset. And then he started screaming because he was in immense pain. Then he was taken to the clinic, and they didn't even know how to deal with this. They didn't even know how should they take out his shoe. So they had to cut out his shoe very carefully, and then they put him in the scanner. And the amazing thing was that on the way, he had to be given opioids so that he could get over the pain, so that they could do anything. And he indeed responded. So he had less pain after that. And slowly, then they could take out the shoe. Then they first saw there was not a single drop of blood. There was not even a scratch. And why was that? Because the nail was neatly wedged between two toes, right? So, did this guy lie? Was he lying? Was he trying to get attention? Absolutely not. He was in pain. Did his nervous system let him down? No. The nervous system did a great job. Why was that? Because what is it, going back again, what is it designed for? It's designed to say, if there's danger, you need to be warned before your body is hurt, right? And secondly, again, then this brings the point, pain is a multi-dimensional experience where you have multi-sensory input. His eyes were seeing there is a problem. He was listening to the cries of his co-workers, their shocked faces. He remembered he had previous experience. Other co-workers had had similar accidents, and they probably even lost their job because of that. And that all taken together led to a composite answer in the brain, and that answer was intense pain. And that pain was designed for him to get protection, to get help, right? And that's what pain is. So pain is not just where you have an injury and then something hurts. Pain is a warning system, and that takes multiple experiences into account. So the second part of the story, again, is a construction worker. It's a very, very dangerous job, as you see. And he was working with a nail pistol. And, he was working, talking with his friends and so on. He anyway had a mild tooth pain to begin with. He had a appointment with the dentist scheduled a week later. So he was anyway going to go. While he was shaving, he noticed there was a small bruise on his chin. But then for 6 days, he happily ate with his family, slept and worked. And then when he went to the dentist noticed some things wrong, and then he was sent for a scan. And this is what was found, right? So it's a true story. And I, of course, accept that it's an anecdote. It makes for nice stories, but it does drive home a point. And in fact, happy to discuss this later. I've been given a tight timeline, so I'll move on. But this shows you, pain is in the head. I mean, it's when your brain says it's pain, it's pain. If the brain doesn't say it's pain, no matter what you do, it's not pain. And I'd like to now come back to what are the issues we are having. So we've come a long way in the pain field to recognize this. In a way, it's a little bit of a defeat for people like me, right, who like to, cut stuff and then look at which molecule is expressed, and then I'd like to assign that molecule a very particular role, in saying this is what causes pain. But again, I think it's a multidimensional experience that has to come together. And indeed, in our field, we have people, excellent people, and we have Ann-Christine Pfeiffer here. She already mentioned in her introduction, she's looking at psychological factors such as expectation, catastrophizing, anxiety, and so on. We have people, excellent people, that look at social factors, and indeed, early childhood experiences. I think you also mentioned that, whether you're deprived or enriched environment, how much social support do you have, and whether that leads to actually supports you against pain, or does it actually even intensify your pain? These kind of things are being studied. And then there are people like me, which are very comfortable in our little zone here because we keep testing, mechanisms of neural sensitization. So the problem in our field is that we barely talk with each other. We all work in our own silos, and and it's like the story of the elephant, right? With 7 blind men, one man with a blind man is sort of testing the tail and says, well, I think an elephant is long and thin, and another one might be touching the ear, and says, no, an elephant, is flat and large, but the elephant is nothing like that, right? And that's why we need to work together with each other. This is something we are now trying. We are trying to cross this chasm and work with each other. And for example, I've taken up the topic of the relationship between pain and fear, and there I do have the hope that by overcoming fear, you can overcome pain. A large part of chronic pain is actually fear and chronic fear. And we're working also on the neurobiological basis of that. So now in our field, we talk about multimodal therapy. This has been around for a while: physiotherapy, Verhaltenstherapy, as you say in German, cognitive behavioral therapy. Also, you need empathy and support from the family and society. And I'm here, pharmacologist, but what we have now understood over time is it doesn't make sense to just throw a bunch of opioids at people. What we need to do more is to first understand the mechanisms and then have a mechanistically targeted pharmacological therapy, particularly that's tailor-made to that type of pain. And we believe now more in enhancing your endogenous inhibitory or resilience systems rather than taking something exogenous that depresses you, because when that depresses your pain, it's also going to depress a lot of other things, including your psyche and so on, and your cognitive aspects. And slowly but surely, we are trying to move towards personalized therapy for chronic pain. So, and I have the pain center to thank for that. If I have 2 more minutes, I would like to talk about crisis and pain from a couple of other angles, because that's how I also understood I could bring a relation. So, in health crisis, whenever we have a health crisis, we also have an impact on pain. So, for example, the COVID pandemic, but much more actually long COVID and post-COVID, the very strong symptoms of that are actually apparent in pain. And in fact, my colleague Andreas May-Lindberg, who heads the Central Institute of Mental Health, actually called me up after COVID, and he said, you know what? I thought people are all coming to me because of depression and this and that, but they're all talking about pain somehow. And this is indeed was so it's very interesting how all these factors come together. And another aspect of pain is that it does come up also in times of political crisis, or can lead to political crisis, because it's exploited. And one particularly hard to think to talk about is fetal pain, I think. And I think some of you might be aware that the US Republicans, for example, used, they claimed that, or they used pain to make the point that a fetus is a person, because a fetus feels pain already starting from 20 weeks. Now, that flies in the face of science, because medical science shows that there's not even any connection between the thalamus and the brain with the periphery at that time. There are some reflexes which also paraplegics or quadriplegics have, and unlike the fetuses, the quadriplegics can talk, and they will tell you, yes, I felt a reflex. I basically, my foot moved, but I didn't feel anything. So there was no pain. And again, I want to again assert pain is in the brain. We have to accept that. Then there's also, of course, it's being politically exploited with respect to access to treatments such as medical marijuana. And then again, there are governments, including the current US government, that sort of declare the war on drugs. That sounds very nice, but actually it is something where they are highly persecuting and restricting medical care, because in the end, actually, patients are highly under treated, and by just clamping down on prescription analgesic drugs, what they are actually doing is they are increasing the demand for non-prescription drugs. So they're actually driving pain patients now away from the clinics and on the roads, where they are now they're much more susceptible and will fall prey to all kinds of things. If you're interested in this topic, there's this excellent review by Scott Fishman, because it seems like this is a trend that many governments have used. So again, now in my last two slides, I'm a very small person, and it's not like I'm coming up with truths of any kind, but these are truths that I have learned from great minds and masters, and truths that I write down also for myself. So I don't know how Jonas deals with whenever he gets stuck. I get stuck often. In the biomedical field, you are only as good as your last publication, and then it doesn't matter if you've had a Leibniz Prize or ERC grants, or you are measured by your last publication. So you're always being measured, and you're always getting stuck. So what I say to myself whenever I get stuck is, I say, no matter what's happening around you, you have to stay true to your scientific passion, and that's why you're here, right? And then that also keeps me strong when I see my colleagues jumping on bandwagons, and we can talk about this. There've been so many bandwagons where they, for example, sex differences in pain is surely an important topic. However, I have to say it was highly exaggerated, and you got basically, I mean, you could not publish if you were not talking about sex differences in pain. I find it's an important topic, but I'm not interested in it. And I was not interested in working on it. And I didn't want to work on it. So I didn't jump on that bandwagon. And because of that, I also don't have to jump off the bandwagon now. Now that it's not sexy anymore. Then there's, you have to, I mean, I think science is all about validation. You have to be rigorous. And this is something we all have to adapt. And I still go back to the time in 1991 when I published my first paper, and just before we sent it out, I actually went to my PhD advisor in tears, because I said, you know what, I don't think we should be sending this paper out. And he said, why not? I said, I'm not sure now of anything. Actually, don't know. I don't know any of this, whether any of this is true. I can't, because I just found it so this huge responsibility that something becomes known. A published word is like is a universal truth, and can my work lead? And then he calmed me down and said, you know what, that's not what you're saying. You're saying you did this and that experiment in exactly these on those conditions, so you should describe your conditions properly, exactly how you did them in detail, and be rigorous about your description. And then what you're saying is, under these conditions, when I did this and that, this is what I observed. This is all that you're saying, and this is what your paper is saying. And this is a philosophy I have kept also without drawing huge conclusions. But on the other side, and now this is the prorector for research and especially transfer also talking to you for the future. Research can be your personal passion, but research is never a hobby. We all have a duty. Research is, if we become researchers, it's a duty. It's a huge privilege that we are allowed to do research, which is funded by the public. And therefore, freedom is excellent, but freedom is only true when it comes with responsibility, right? And knowledge shared is knowledge multiplied. However, there's a big trend. I think Jonas alluded to that also, that nowadays value of research is being measured in terms of its use or applicability. And I absolutely reject this notion for myself. The value of research is not given by its use in applications, but how authentic it is and how it contributes to understanding. So for me, Jonas, when you said you're not a scientist, of course you're a scientist, because, because I learned when I came to Germany, the word for science is Wissenschaft.
The Wissenschaft schafft Wissen. So as long as you're creating knowledge, anybody, they are a scientist, right? And with this, I'd like to actually just close, because I don't have the words for it, but excellent people have been thinking about this, about how to rebuild trust. It's not about just getting better journals that, where we don't follow, nature or science cell. It's not about only giving incentives. We could by including the public, right? We don't research over people, we research with people. This is something we can try to develop as a future. But more than anything, science is all about keeping science visibly human. We make mistakes, but in science, when we make mistakes, we go back and correct them. We test them, we quantify things, and then we have the humility to correct and exchange also about this. So with this, I'd like to thank my funders and my research group. I'd also like to, we live by the motto in the pain field, given by Galen von Pergamon, who said that it is really divine to try to relieve pain. But the most important saying for me is much more the motto of our university, which is Semper Apertus. Let's always stay open. Thank you very much for your attention.